Cool. Um, okay. So the last case is actually a consult. I'm so this is a patient with known gastric cancer, and I saw this case during tumor board, and when I first saw this, I was trying to help them with the TNM. So I saw this, nodules around the mesentery, and I called this N1, or just N, like lymph node disease. I'm curious to see what people would say if you saw this. Would you call this lymph node or peritoneal carcinomatosis?
For me, I probably worry more about the latter because I don't see a lot of lymph nodes in that area normally.
Mm-hmm.
And so if you're seeing nodules that are sort of along the gastrocolic ligament, I
Mm-hmm.
worry about it being basically metastatic implants and not just nodal disease.
Mm-hmm.
And no ascites elsewhere, and
No ascites
no
elsewhere. Yeah.
and no nodules
Um,
anywhere else, right?
I didn't see. Oh wait, I think that it was just anteriorly along this area. At least that's what the surgeon told me when she went
Everyone,
and
I mean,
did a cytoreductive.
point well taken from Steve, but if it's just localized there, then it's maybe a
Either or.
combination of local extension and nodes.
Yeah, I agree.
But it's tough.
I would lean away from peritoneal carcinomatosis if it's contiguous and local.
Yeah.
But and even if it like Victoria was saying, if it involves those nodes, those nodes are still within the resection of what they would resect for a gastric cancer, so it would still be regional nodes.
Gotcha. So I said I thought they were lymphadenopathy, and I didn't think about peritoneal carcinomatosis. And the patient was already operated on at the time when I presented this case at tumor board, but it was peritoneal carcinomatosis. And I felt a little embarrassed because I'm like, oh, this looks like lymphadenopathy. But she's like, no, it's carcinosis.
But I think they could, like, given the extent of how extensive this tumor is, they have a high risk of having peritoneal carcinomatosis. So they could have even had it elsewhere in the abdomen that we don't see on a CT scan.
Yeah, whether you see it or not.
When you have like this large of a tumor, even if you didn't see that stuff extending, Nelly, they would do a diagnostic laparoscopy.
Yeah, so that's what exactly. So that's what she did. She went ahead and did a laparoscopic sort of staging, and that's where she saw like blatant carcinomatosis. So patients, I didn't really know this, but up to 20% of patients are found to have peritoneal carcinomatosis when surgeons take the patients to curative resection. That's like not diagnosed, beforehand. And if the serosa is involved, like Arthi said, if it's that extensive, so T3, peritoneal carcinomatosis occurs in up to 50% of cases. And the treatment typically is cytoreductive surgery with peritoneectomy followed by HIPEC, which this patient had. So I was talking to my surgeon because I'm like, well, how do I not get these two things confused in the future? And she said, if it's anterior to the stomach, sort of what Steve said, it's peritoneal carcinomatosis. She said there's no lymph nodes anteriorly. And so if you see that, it's most likely peritoneal carcinomatosis. The other thing she told me was if the serosa is involved, like Arthi said, if it's pretty extensive, then have a high level suspicion for peritoneal carcinomatosis because it occurs in up to 50% of cases. And the other thing was lymph nodes, because I'm trying to help, as I think I was helping, but I don't know that I was helping, trying to like stage this patient and give them the number of lymph nodes that were involved so that they can sort of, have a better understanding. But she said, don't count the number of lymph nodes, just tell them what compartments are involved. So there are 4 main compartments that the surgeons think about. And the newest AJCC criteria make their like lymph nodes that's involving compartment 3 and 4. So the ones that are pointed to by the arrow, these are actually considered M1 disease, not nodal N disease. So so she said, comment on these 4 stations or these 4 compartments because it changes their surgical resection. So if depending on which compartment is involved, they'll do a different type of dissection when they do a cytoreductive surgery. So that's basically it. That's it for me.
One quick comment. My surgeons have told me that they don't want us to definitely call peritoneal disease if it's extending from the stomach. Like they don't want us to overcall that. Although they still might have, like you're saying, like a high suspicion and do a laparoscopy.
Yeah.
But not just say like that there's metastatic disease if it's contiguous with the stomach.
Gotcha. Okay. All right. So, and what would you have said for this? It's just local extension of tumor?
Yeah, I would say like extensive tumor with like extensive local extension of tumor likely into the nodal areas there. And then no peritoneal nodules separate from this region.
Gotcha.
And then like let them go from that.
Gotcha.
But the big ones, yeah, like you were saying, like celiac axis, SMA nodes, retroperitoneal nodes, those are like the metastatic nodes. So those make a big difference too.
Yeah, and the porta hepatis. Yeah. Cool. That's it for me.